That was such an important talk, and having been gone through all the exams, we do realize the importance of the importance that this talk holds, and in the exam point of view and in the clinical setting. So I request Dr. Sirkini sir, sorry, to present Dr. Satish Govind sir with a token of gratitude.
I need to make a small point here. To make a small point here. When we were planning this program and we asked Satish if he would be, glad to join us, he's got his own program today afternoon. So he said, he's not going to miss it for anything. Thank you, sir, for being a part of our family. And he's going here for his own function. So much so that he's given this precedence over his own function. Thank you, sir. Thank you again. Sorry. Another point is this is something which we put up in the first part of the talk because both me and ma'am, when we were correcting papers, realized that this was coming almost every single year. I'm sure all teachers will agree to this. Every single year, this topic has come. Even if you just write the headings of what he has discussed, you will get 8 on 10. And it comes as a 10 marker. It has come as a 5 marker. It has come as complications when you have your 10 into 5 questions. It has come as 2 markers when they have asked only name the complications. Every part of this talk has been asked, as Sir said also. So please be very conversant with ECO and CAD. It will never be missed out in any of your exams. It will always be asked. If it's not asked in theory, it will be asked in practicals, as they have said to actually show you that. So it's a very important topic. I hope you have picked up the slides. If not, then we'll share it with you later.
May I call upon Dr. Srikanth sir for his talk on eco advancements in DSC. Thank you.
Okay, shall we start? Yes, yes or no? All right, so pay attention because we're going to focus on stress echo.
All of you are very privileged to be here, and all of you are very lucky to be here. So my request to you all is to please participate. So it's very easy to sit at the back, and you might even fall asleep sometimes. Even if some front benchers might fall asleep. But the point is actually for the Karnataka government and the RGHS University that you are all a part of, Rajesh Shinoy sir has brought this program to your doorsteps. Let me be very honest with you. He was the one who just sent the message across to all the principals, all the HODs. In a flash, the whole state knew that this conference is being held. And at whatever short notice, how many of you have come, that's all because of the efforts of the faculty here. That is especially Sir Rajesh Shinoy sir, who has just immediately spread the message across and got you all here. So having come here, please make use of it and take advantage. When sir asks a question, the first question is always, are you attentive or are you listening? So at least, you can start from there, showing your interest, your enthusiasm, and the fact that you are awake. So please, please, please participate. This conference is yours. Okay. It's my request to all of you. Don't feel that you are from, like Prag has already said, it's not this hospital or any other hospital. Please participate. Thank you. Thank you, sir.
Thank you. Well said, ma'am. Well said. All right, so let's start with stress echo and what you need to know to pass your exams, but also what you need to know to do stress echoes properly, to understand what you're doing, how to stay out of trouble, when to do them, and when not to do them. So I'm going to talk about indications and contraindications. We'll go over exercise as well as pharmacologic stress, some tips and tricks, which I think you'll find to be very useful in your day-to-day practice, and a little bit about interpreting stress echo. There are some special indications for stress echo like viability, valvular heart disease, HOCM. I'm not going to talk so much about those. We'll focus on this upper part in the next 20 minutes. Now, the most common reason to do stress echo is mainly for ischemia. Does this patient have coronary artery disease or not? What Dr. Satish Govind in the last talk just talked about, this is the most common reason. Patients with chest pain or exertional dyspnea that's suspicious for coronary artery disease, or patients who are going for non-cardiac surgery who need to be evaluated for their cardiac risk. Now, you also need to know when not to do stress echo, okay? When not to do stress echo. This is really important. Please don't do stress echo in patients with unstable angina, patients who are having active symptoms, in patients with uncontrolled hypertension. Sometimes it happens that, we tell our patients before a dobutamine stress echo to stop their beta blockers, right? Before the exam. Then what happens is their blood pressure goes too high and we may not be able to do the test as planned. Patients with LV thrombus, so as Satish sir showed in the last talk, patients with LV thrombus, don't submit them to stress echo. Patients with unstable arrhythmias, and here I'm not talking about AFib or flutter, I'm talking about ventricular arrhythmias or even frequent TVCs, which can make it difficult to image these patients. Patients with critical aortic stenosis, although we do often do stress echo with, not often, but sometimes do stress echo in patients with low flow, low output, or low EF, low output type of aortic stenosis. Hypertrophic cardiomyopathy is not done for dobutamine stress echo, but we can do them for stress echo when we're looking at provocable gradients. The patient already has a gradient at rest, it's generally not required. But if we're trying to look for provocable gradients in a patient with hypertrophic cardiomyopathy, then we will do exercise stress echo. And obviously, patients with decompensated heart failure, if they can't lie down, if they have orthopnea, these are not the patients to do that. There are a couple of other things too. When I was at Duke University, we got a requisition to our echo lab, exercise stress echo. Patient is going for pre-op evaluation for some non-cardiac surgery. Okay, fine. The patient got to the echo lab for his exercise stress echo, but he had a below the knee amputation on one of his legs. We were like, so check that the patient can actually exercise before you submit them to an exercise stress echo. Now, let me ask you, how many of you are doing dobutamine stress echoes in your hospital? Raise your hands. Let's see. How come the rest of you not doing? Why? Why? Somebody shout out. Not doing dobutamine stress echoes. See, it doesn't matter if you're doing this or not doing dobutamine stress echoes. Your examiner is going to ask you about this. Okay, so you need to know this. How many of you are doing exercise stress echoes in your hospital? Let's see a show of hands. Okay, yeah, this is actually really important. How long does it take to do a DSC? 45 minutes, yeah. Yeah, how long does it take to do an exercise stress echo? 20 minutes max, right? 25 minutes max. So your throughput in your echo lab is much faster if you're doing these. When do you do stress echoes in general for patients with CAD? Patients who can't exercise or they exercise submaximally on a treadmill. Maybe they have some orthopedic or neurologic issues. Patients who you send them for their TMT, their ECG, but it's not suitable for a treadmill test because of repolarization abnormalities or whatever. And you know what? Please, guys, this is especially for the residents here, don't do treadmill testing for patients with prior PTCA or CABG. It's a lousy test in those patients. So don't do TMT for these patients. Do an exercise stress echo for such patients if they're able to, please. The utility of TMT in these patients is very limited. Now, you need to know this slide, okay? Just imprint this into your retina. This is the ischemic cascade, and it shows why treadmill tests work. It shows why stress echo tests work. It shows why SPECT or perfusion imaging work. You just need to know this. Now, normally, this is a short axis image of the heart, okay? And in a normal patient, what happens during diastole, the muscle is relatively thin, not thinned, but it's normal thickness, right? And then during systole, where this lighter text is, you see that the muscle is much thicker, right? So there should be some normal thickening during systole. This is what happens in normal function. Now, let's say that the patient has some infarction or they have some severe stenosis or something. So the first thing that will happen as you get worsening ischemia or flow reduction is that you'll start to see a perfusion defect. So this is where tests like adenosine stress perfusion MRI or SPECT, for example, or the cardiac PET, this is where these tests are looking for, okay? Then you start to see diastolic relaxation abnormalities. We typically don't test for these. Then you start to see strain, abnormal strain. This is something that we do sometimes in stress echo. But then you start to see abnormal wall motion, what Dr. Satish was showing in the previous talk here. That is, these segments may thicken normally, but the segments which is affected by coronary artery disease might have new onset hypokinesis, akinesis, or even dyskinesis. And then you get ECG changes, which is what we look at for treadmill testing. And then finally, you get angina, and then you don't want to see infarction or scar. Sometimes you'll get angina without any of these things. That's at least any ECG changes or wall motion abnormality. That's certainly true. But generally, this is the order. And this ischemic cascade, you just need to know this, okay? Just know it. I'm just telling you right now. You just need to know this. So when we do stress echo, what we're looking at is we're looking mainly in this area here, visible wall motion abnormality. This is what we're looking for. Now, there are some things, while we always start with the TMT because it's widely available, it's cheap, it's easy to do, there's a whole lot of reasons why treadmill testing doesn't work. As Dr. Satish said, maybe they have a left bundle branch block, some other type of conduction abnormality. Maybe the patient has a pacemaker. Maybe they have baseline ST abnormalities because at LVH, sometimes the Joxin, we don't see that so often these days, a prior MI, or maybe they're just not able to reach their target heart rate, which would be 85% of their age predicted maximum heart rate. So let's go on then to exercise stress echo, because this is my favorite. And I don't mean exercise stress testing, but for the purpose of this talk, exercise stress echo. You can do this on a treadmill. That's how we do it most often in India. In some places, especially in Europe, they would like to do this on a supine bicycle. This is when I was at Duke, and we would do this on a supine bicycle. This works okay, but in some older women, you'll find that they just don't know how to ride a bicycle as well. So it's not used so commonly in Southeast Asia, for example. It's got its advantages and disadvantages, but just know that typically it's done on a treadmill when we do exercise stress echo, but you can use a supine bicycle. Why do we like exercise stress echo? Apart from the fact that it's faster, well, you can also look at physical workload. You can get your METs, right? You can get your how long the patient exercised. You can also look at your ECG and you get ST segment evaluation. You typically get a better cardiac workload. So you're stressing the patient more with exercise than you do with pharmacologic stress. And probably it has just slightly better sensitivity, not a huge amount, but slightly better sensitivity. And as I mentioned, yeah, it's really fast compared to a Dobutamine stress echo. And that's important in a busy echo lab. But there are a lot of patients who can't do stress echo. Let's say you have a patient who's 75 years old who comes to you for pre-op hip evaluation. They're not going to get on a treadmill. And so pharmacologic stress testing is used a lot in our echo labs. And you have three options, but really only one that we use most commonly. But you need to know this for your exams. Maybe you're using sympathomimetic agents like dobutamine. Maybe you're using vasodilator agents like adenosine. Regadenoson is used in other countries, dipyridamole, and atrial pacing is rarely used. I haven't seen these. According to the latest guidelines, dobutamine is the pharmacological stress agent of choice. And what this does is it increases contractility, so it's a positive inotrope. It increases heart rate, so it's a positive chronotrope. And when you combine these together, it increases wall stress, so you're more likely to assess for ischemia. Dobutamine at low dose is going to have mainly an inotropic effect. It's going to increase contractility by stimulating both the alpha and beta 1 receptors. At high dose of dobutamine, typically more than 10 micrograms per kilogram per minute, it's going to stimulate the beta 2, so you're going to get more of a chronotropic reaction. That means the heart rate is going to increase. Now, these are practical things to know, okay? This is stuff you need to know. The half-life is 2 to 3 minutes. That means once you stop the dobutamine drip, the effects go away within generally 5 minutes. You can trigger tachyarrhythmias, either atrial or ventricular arrhythmias. So don't use this in patients with recent VTAC, VFib, that kind of stuff. It can cause hypertension most commonly, but in some patients you get hypotension with dobutamine. So you need to monitor blood pressure during a dobutamine stress echo. And you'll find, chest pain, nausea, sometimes vomiting, headache, tremors, palpitations. These will happen. They all go away within 5 minutes of stopping the infusion. How do you start? You're going to start at 10 mics per kilogram per minute. Typically, you have a table in your echo lab that tells you how many milligrams that is to mix into the syringe. If it's a viability study, instead of starting at 10, you will start at 5 mics. And then whatever it is, whether it's adenosine or whether it's viability or ischemia, you increase the dose to every 3 minutes to 20, 30, 40, until you get to 85% of your max age predicted maximum heart rate. If the patient is still not reaching that heart rate, despite going to 40 mics of dobutamine, then you can do a simple thing. You can give them a tennis ball to take in their hand and then just squeeze the tennis ball. And that kind of isometric contraction will cause the heart rate to increase by 5 or 10 beats per minute. In some countries, instead of a tennis ball, they actually have these contraptions, like those hand exercisers, which give you a very specific amount of stress. Otherwise, you can give atropine at the standard doses of 0.3. One thing to note, if by the time you reach 20 mics of dobutamine, if the heart rate is still not getting to 100, that means the patient is on beta blocker or has some kind of chronotropic incompetence, and you're unlikely to reach target heart rate. So just remember this when you do these exams. Okay, let's do some practical tips and tricks. What should you know? Obviously, get informed consent. Make sure you check the patient identity. Make sure the patient has stopped their beta blockers for 12 hours. Make sure the patient has no active chest pain or dyspnea at rest, and they need to have good echo windows, right? Remember, a picture is worth 1,000 words, but a great picture is worth much, much more. So if you don't have that, and if you don't have contrast in your lab, then send the patient back. Record the images and send the patient back. You're going to load up dobutamine. You're going to load up atropine. You're going to load up saline. So make sure all the syringes are labeled with the name of the medication or normal saline flush and the date. Make sure your defibrillator and your crash cart is working. Consultants are readily available. In many places, like when I was in the United States, a consultant would come and be present physically, or at least a cardiology fellow would be present physically during a DSC test. Not so much for an exercise test, but definitely for DSCs. If it's an exercise stress echo, the patient, you're going to take your baseline images, the patient's going to run on the treadmill, and then you have to quickly transfer them back to the echo bed to be able to do your post imaging. So what you need to do before you do your baseline images, you get the patient on the treadmill, just have them walk like for 10, 20 seconds, and then have them practice shifting back to the bed quickly. Okay. Otherwise, what will happen is they'll turn around like this, like that. And, by the time you get them back on the bed and get them where they need to be, already 1 minute is gone. And the sensitivity declines rapidly within even 90 seconds after you stop exercise. So show them, practice if you're doing exercise stress echo, how to shift from the treadmill to the bed. A few other things, if you've got a 3D machine or 4D machine, then use that. That makes it much easier. You can use a lower plaques view when you're doing the parasternal long axis view, because I want to see the LV. I don't care about the atrium in stress echoes. If I'm doing 3D imaging, I want to see the mid-parasternal short axis view, although now the newer machines will allow you to see basal, mid, and apical short axis all in one time. That's really nice. For apical views, adjust the depth for apical windows, adjust the depth because I just want to see the LV. I don't care about the atrium. And remember, record the breath held and end expiration so that you get better images. All right, last 2 minutes, let's just talk very briefly about how do you interpret stress echo. This is a big talk just by itself, so we'll go through this. Normally, what happens is that contractility should increase globally. You will get hyperdynamic wall motion, heart rate and wall thickness is going to increase, and cavity size will get smaller during stress. So let's take a look at this. This is a stress echo. This is baseline here for the parasternal windows and for the apical windows on the bottom row. And what you can see on this parasternal long axis view is maybe some mid anterior septal hypokinesis, which remains, but the other segments get better at peak stress. And on this short axis view, yeah, again, maybe some mild, maybe not so much here, but mild, but it's all getting better. Okay, so this looks good. Now, when you get to your 4-chamber, your apical windows, sorry, you've got your 4-chamber, your 2-chamber, and your 3-chamber. And as Dr. Satish said, you really need to pay attention on getting these anterior walls and on the lateral wall. One is because you have the ultrasound beam is now parallel to the direction of these walls. And number 2, because you can get lung shadow. So really optimize these windows. But you can see here, look at what's happening to this apex here versus here. Can you appreciate that? Yeah, you've got decreased contractility. It's normal here, and it's become hypo or maybe akinetic, even dyskinetic in this distal inferior septal and apical segment. And the same thing is true. This looks like an LAD lesion. Now, how do we do this most commonly? Mainly we look at changes in wall thickening. Don't get fooled by tethering. Tethering means I've got a segment that's bad and it's getting pulled by a normal segment. Okay, what we're looking at is increase in thickness, and that's how you assess a stress echo. Look also for LV cavity dilation. Why? Because when you're doing the stress echo, okay, if you don't recognize that a patient is getting ischemia on the stress echo and you just continue with the stress echo and then the patient crashes or has a problem, you're going to be at fault. The consultant is going to say, boss, didn't you see that the LV cavity was getting dilated? And that's a sign of multivessel CAD. They're going to say, ma'am, didn't you see that this patient already had multiple wall motion abnormalities that were worse? So while you may not be the one interpreting the stress echo, you better know what's an abnormal stress echo, because if that happens, if the patient is showing signs of ischemia, even at low dose dobutamine, you're going to stop the test. Now, normally what happens is that resting function gets, in a normal patient, resting function is normal. You give low dose dobutamine, it gets normal, and at high dose, it gets even hyperkinetic. If the patient has ischemia, it'll be normal, and then it'll be low dose, so it'll be normal, or maybe a new wall motion abnormality that gets worse at peak. If it's infarcted by myocardium, it'll have a wall motion abnormality at rest, which really doesn't change at low dose or high dose. If you're going to do a viability test, you'll have some resting wall motion abnormality, same like here, but it'll get better at low dose, and then it'll get worse at, depending on it, it'll get worse typically at higher dose dobutamine. So this is something, again, that you need to memorize. You need to memorize this. Just know this. Dr. Satish showed the same thing. And then you need to know your wall motion score index as well, which is easy to do, but just make sure that you practice it so you understand. Last minute, let's just go over 1 or 2 cases here. Look at this dobutamine stress echo at rest, low dose dobutamine here. This is peak dose here, and this is recovery on the bottom right. So you can see that looks like there's an anterior septal MI. It's hyperechoic, and there's resting wall motion abnormalities at low dose, at rest, which do not get better at low dose, and which stay the same, don't get better at high dose. So this anterior septal wall is dead. It's not viable. Nothing is happening. But if you look at the inferior lateral wall, it's maybe hypokinetic at rest. It gets slightly better at low dose, gets better still at high dose, and then has, again, normal function at recovery. So this infralateral wall, nothing is wrong with it. Let's go to the short axis images here. You can see this anterior septal wall is what, akinetic here, anterior septal, inferior septal, and anterior wall is probably the same and akinetic as well. At low dose, there's no improvement. Okay, so that means it's non-viable. At high dose, now it's become dyskinetic. So that means this is, again, all infarcted dead tissue. And the same thing happens, it goes back to the same during recovery. But look at the inferior wall here. Okay, let's pay attention to this. This looks quite fine, the inferior, and at least what we can see, the inferolateral wall. And then when you look here, what happens here? Take a look at this LV cavity. Take a look at this LV cavity. Guys, what's happening? It's dilated, yeah? What does that mean? Multivessel disease, no? Okay, so if you see this, you better pay attention. See here, look at the lateral wall. It's getting better, no? Look at the inferior septal wall. It's hyperechoic, it's thick, it's probably infarcted. But you can see that at the basal inferior septal is getting better at low dose. Good. Lateral wall getting better at low dose. Good. But look at peak stress. What happens to the lateral wall? Is it same, better, or worse? It's worse, right? So what does that mean? Ischemia, non-ischemia? Ischemia. All right. So good. So you're happy. So you finish this stage and you go on to here and you see that it recovers. Look at this one. It continues to get better, right? Okay, fine. So this is, in short, how you're going to assess this. There are other ways like strain, and that's a whole separate talk, so I won't cover that on this topic. There are reasons why you can get false positives and false negatives. Make sure you give good enough stress. Make sure you stop anti-anginal therapy, especially beta blockers. You might miss mild coronary disease. Left circumflex disease typically has the least sensitivity, and make sure you get good images, right? Remember that in patients who have lots of wall motion abnormalities at rest, like cardiomyopathies or lots of CAD, these are hard tests to do. So don't do dobutamine stress in patients with EF of 25, 30% and stuff. It's hard. If you do dobutamine stress for patients with EF of 40% and above, it's much easier in those things. And remember that the basal inferior wall often gives you false positives on these stress echoes. Okay, so let's just wrap up then. We've talked about indications and contraindications. Know these. Know about how to do an exercise stress echo. Know how to do a dobutamine stress echo. Understand the practical implications of doing stress echo, and make sure you know the basics of interpreting stress echoes, because you need to know this as you're doing your exams. Thank you guys for your attention, and all the best for your exam.
Thank you, sir, for putting light. Thank you, sir, for putting light on the assessment and the proper interpretation of dobutamine stress echo. I request